Hi, my name is Talid El-Sabawi, and I will be presenting today about the need for building a person-centered mental health emergency response. And I'll be presenting on a model law that we have that helps actualize that. So, like I said, my name is Talid El-Sabawi, and I'm an assistant professor of law. I am also a scholar with the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown Law Center. The drastic rise in both mental health and substance use related health crises in the US indicates that now more than ever, states need to revisit how they handle emergency calls. In most states, emergency calls for any behavioral health crises are routed through 911 dispatch, and police officers, not mental health treatment professionals or substance use treatment professionals, are the ones that are dispatched. When they're dispatched, they're more likely to forcibly commit or arrest persons amidst a crisis. And many jurisdictions continue this practice despite the growing evidence that we have that persons with behavioral health concerns are significantly more likely to experience excessive use of force that result in injury or death during these police encounters. So studies involving persons living with schizophrenia or a schizoaffective disorder have found that 48% of participants experience contact with the police during the study period. Current estimates suggest that 1% of all law enforcement dispatches and encounters involve an individual living with one or more mental disorders, excluding substance use. But aren't persons with mental illness more violent? Now, some might assume that contact with law enforcement is a result of violent behavior on behalf of the person that's living with the mental illness. But that's actually not most likely the case. Researchers who conduct studies on this topic have noted that individuals with a mental illness were 14 times more likely to be the victims of a violent crime than to be arrested for allegedly committing one. Now, when we talk about mental illness and criminal justice intersections, it typically is that persons who are arrested that have a mental illness are arrested with crimes against public disorder or public order. So one study, for example, showed that over a 10-year period, the majority or 65% of the individuals who experienced arrest were detained in connection with a crime against public order. So this suggests that most of the concerns that law enforcement were dispatched to respond to involved the symptoms of the mental illness, not actual criminogenic behavior. So, crimes against public disorder are defined differently across different jurisdictions, but most frequently they encompass drug or alcohol-related crimes, public drunkenness, or just disorderly conduct. Now, when people with mental illness or substance use disorders encounter police, they're more likely to suffer injuries during these encounters. So individuals treated for injuries sustained during law enforcement intervention were 1.4 times more likely to be living with an alcohol use disorder, 1.7 times more likely to be living with a substance use disorder, 2.4 times more likely to be living with depression, 2.8 times to be more likely living with a paralytic condition, and 8.6 times more likely to be living with schizophrenia. Studies have also shown a high degree of stigma harbored by law enforcement against persons with mental illness. Now, we know that restraints or the use of restraints by law enforcement contribute significantly to the injuries that are suffered by persons who are experiencing behavioral health concerns. In Greensboro, on September 8th of 2018, the Greensboro Police Department encountered a 38-year-old Black man that was later identified as Marcus Deion Smith, who was running in and out of traffic in downtown Greensboro, North Carolina. Now, Mr. Smith was a person with a documented mental illness. and he was experiencing a emergency crisis. He approached the officers and asked them for help. Now, I'm not going to play the video because it is relatively, it's traumatizing. I'm just going to read some of the transcript to you. So Mr. Smith approached the officers saying, "Please, sir, please help me, sir. They're going to kill me. I want to go to the hospital." Now, Mr. Smith was again suffering from a behavioral health crisis. The police responded to his cries for help by saying, "Boss man, you need to chill out." And then they put him in the back of a squad car. Now, this confinement further agitated Mr. Smith, who began banging on the squad car windows. Police response was just, quote, "He's just bugging out on something." So then the officers decided they should rip hobble him or put him in a restraint that has been identified by the Department of Justice as one that can interfere with an individual's ability to breathe. Still, the police officers put him in this position amidst him yelling, "I ain't resisting." Now, Mr. Smith, after he was hogtied, was no longer breathing, and he died after being transported to the hospital. The medical examiner ruled Mr. Smith's death as a homicide. And in sum, the public officials in Greensboro condoned the actions of the police officers, indicating that police officers had behaved as they were trained and expected to behave. And herein, my friends, lies the crux of the policy problem. Mr. Smith was not the first to die from this type of restraint amidst a behavioral health crisis. But he was just one of the most recent and visible cases locally. Despite these deaths that have been occurring at the hands of law enforcement, due to a number of historical and circumstantial factors that I'm not going to get into today, police have become the default first responders for behavioral health crises. So just a quick overview of first responder models to behavioral health crisis. Most jurisdictions, most local governments still send out police with no training to respond to behavioral health crises. Now, some jurisdictions have trained some of their law enforcement with what is called crisis interdisciplinary training, or CIT, as to how to respond to behavioral health crises. And I'm going to talk a little bit more about CIT in just a moment. The third type of model is it's called a co-responder model. Colloquially, it is sending a police with a clinician or a social worker, like a ride along. It can also be a dual dispatch, where police are sent in first and then clinicians or social workers are sent in second. And the fourth, the model that we support and have created a model law for, is a non-police response. And I'm going to talk a little bit about why. Going a little bit too fast there. All right, so CIT programs. Now, CIT programs are based on what's called the Memphis model, and they began in 1988 in Memphis, Tennessee, following the shooting death of 27-year-old Joseph Dwayne Robinson at the hands of Memphis police. So on September 24th, 1987, Robinson's mother called 911 to report that her son, who was living with chronic mental illness and substance use disorder, was in the area just outside of her home, allegedly cutting himself with a knife and verbally threatening others. And according to reports made by 4 police that were dispatched there, Mr. Robinson was stabbing himself in the neck with a butcher's knife when they arrived. The officers claimed that Mr. Robinson lunged at them as they approached, and they fired no less than 10 times. Following public outcry over the shooting, the National Alliance on Mental Illness, NAMI, facilitated discussions between law enforcement in the wider community, and the Memphis model of CIT was born. Since then, CIT, or some variation of it, has been rapidly adopted and is widespread in the U.S. For example, by the time the first study or scholarly manuscript that really described the CIT framework emerged in the literature at around 2008. There were already CIT programs in 400 law enforcement agencies. So CIT components differ by jurisdictions. Most require a 40-hour-ish comprehensive training. There should be a fully established or staffed CIT leadership team and an established partnership with a specialized mental health care facility. What we have seen is that a lot of jurisdictions enacting CIT are not including all of the components and maybe only having short trainings for law enforcement without the other components. So what's the evidence base for these programs? Well, surprisingly, the evidence base for CIT programs has been limited to the evaluation, really, of officer level outcomes. So this includes law enforcement officers' ability to identify someone living with a mental illness or their reported confidence in responding to calls involving an individual with mental illness. Now, there are a few studies that show that CIT programs can improve outcomes, but those are mostly due to increasing officer knowledge and confidence. They do not appear to decrease outcomes of interest with the persons who are suffering the crisis, aside from perhaps linking the person with treatment. As far as whether or not it decreases the person who's amidst the crisis from experiencing excessive use of force, we don't have evidence showing that that's actually the case. So there's no significant evidence that shows that even as officers become more knowledgeable and competent, that there are changes in the way calls are disposed or the patterns of police force that are used. So the evidence base, despite CIT programs being so widely adopted, the evidence base for them is not very strong. There is even one study that suggests that officers that had received CIT training found that individuals perceived to be living with a mental or behavioral health disorder by police officers were more likely to be the subject of force and more likely to be perceived by the law enforcement officers as violently resisting arrest. So there may be some adverse effects by CIT training. So the second type of model we mentioned are co-responder models, and we said those are duly dispatched models. They're often coupled with CIT training for the officers. Well, what about evidence-based for co-responder models? Co-responder models have been popular as of late. We don't have a lot of evidence base for the co-responder models. There we go. A 2018 systematic review found that there's really insufficient evidence to conclude any positive benefit associated with co-responder models, such as reduction in arrest, that couldn't be attributed to the co-responder approach directly. So they also found that sending out a law enforcement officer with a clinician re-traumatized the person that was experiencing a behavioral health crisis. The one benefit that does seem to come out of co-responder models is perhaps more timely linkage with care. But that is because there is a clinician that is sent or a social worker that is sent along, not because of the law enforcement component. We also have evidence from post-overdose outreach. Post-overdose outreach programs send a law enforcement officer with a harm reduction worker to respond after somebody has overdosed. We found that 57% of the programs the researchers found that 50% of these programs actually check for warrants against the overdose survivor before conducting the outreach, and 11% will arrest the overdose survivor on the authority of that warrant in lieu of providing the help that is needed. So these co-responder models don't have a strong evidence base either, which is why we support non-police responses. Now, these non-police responses can come in different flavors. They can be led by a clinician, they can be led by a social worker, or they can be non-clinician based, led by a crisis worker or a peer worker. Cahoots is an example of a crisis worker-led program. We support crisis worker-led programs because the limited evidence that we have from co-responder models that have clinicians included, particularly clinicians, lead to more involuntary commitments than crisis-led responses. So our model proposes that first responders to behavioral health crisis should be non-police crisis workers. And we did use Cahoots, which many of you I'm sure are familiar with, as our primary model. Now, we define behavioral health crisis a bit broadly to not only include mental health crises or chaotic substance use, but also any public disturbances, quote unquote, that could arise because someone is unhoused. So Cahoots has been operating in Eugene, Oregon. We conducted interviews with their staff before we drafted our model law. We chose Cahoots because they operated for 2 decades, providing non-police crisis response, and have shown a tremendous cost savings to the city, to Eugene, Oregon. Now, for those of you familiar with the Cahoots program, you're going to see that our model law has some differences. And I want to talk a little bit really quickly about why we instituted some of these changes. Now, Cahoots operates in Eugene, Oregon, which is a relatively politically progressive place, and we wanted to be able to replicate the model in both progressive and conservative jurisdictions. So we were worried about law enforcement co-option or provider co-option, that this would be turned into just another outreach program that involuntarily or commits or subordinates people with behavioral health crises. So we did interviews with persons with lived experience in designing this program, and we included some of the requests that they had and tried to address some of the fears, which included provider and law enforcement co-option. Also, Cahoots is able to draw on resources and expertise of the Whitebird Clinic, which has earned the respect of the surrounding community over decades. And not all local governments are able to access such positive resources or community clinics as the Whitebird Clinic. We included and modeled some of the best practices of emergency response that were included in recent government guidelines as well. So what does our non-police response team look like? So we have a model law that sets out the creation of a behavioral health crisis response team. There's 2 components. The first, there needs to be a trained emergency call center. This could be the 911 call center that then is trained to also handle behavioral health calls, or it can be a specialized call center. We don't specify, and we leave that to the local governments and advocates to decide. The dispatch team is made up of three persons, one person extra than the Cahoots team. So we have the EMT, or the trained emergency medical technician, to respond to first aid needs, overdoses, et cetera. And then a trained mental health crisis worker, which is not a clinician, but is somebody who has been trained in crisis response and de-escalation. The third person on the team, the behavioral health consumer, was added so that we could make sure that there was a peer, if you would like to call it a peer, who is there to help guide the person who is amidst the crisis, who understands what they're going through, and their entire role is to be a peer or patient advocate, right? So we use the term behavioral health consumer to refer to the history of the consumer movement amongst mental health policy advocates in the 60s that wanted to take ownership back over their treatment decision making. And we stayed away from using the word peer because peer has particular connotations when it comes to substance use disorder treatment. And also because in some states, peer has actually been codified into the law, and it is a licensed specialty. You can become a peer specialist. And we did not want to just limit this to peer specialists. So we used behavioral health consumer. Again, this is a person with lived experience as a recipient of the behavioral health care system. And their primary role is to just be supportive and empowering and to make sure that the person amidst crisis has agency, and that the least restrictive method is used to respond to the crisis. So the person amidst crisis is not coerced, involuntarily committed, or forced into treatment. So I don't expect you to read all of this. It's on the slide. I merely put it up here so that you can note what sections I might be talking about. The law is attached to the paper and the link has been provided for you. Just to point out that we did base these on national guidelines, and this law has been drafted so that it can be enacted by city, county, or state level governments. So anytime you see these brackets, it's because you can substitute out some of the wording to make it appropriate for the level of government. I'm going to skip section 3, which is a long section that talks about specific definitions for the sake of time. But I did want to make sure everybody knows that they are important, and we spent a lot of time on them because based on the feedback of groups that we talked to, we wanted to define the terms that we used in the Act in the most person-centered way possible. And so we did elicit significant feedback. So the wording that we use in the law is informed by the lived experience of persons that would be affected by the law. And we encourage anybody who's looking to propose it or encourage policymakers to propose it to change the language to reflect the community. The key part of the section, and one that was very important for us, but has been difficult for us to get policymakers to acknowledge or adopt, is this idea of an advisory board. The advisory board is meant to be a protective factor or protective component against co-option. We structured the advisory board to allow for representatives from provider groups, but we wanted to maintain the board's control by vulnerable community members. And to do that, we required that there's a simple majority of board seats be given to community members at any given time, and that it be a public application process, that it not be nepotism where, a lot of what we're seeing a lot is local policymakers will form an advisory group, but then they will choose who gets appointed to the advisory group. And there will be a lot of providers or law enforcement officers. I'm not saying not to include those folks, but the power and the control should remain with the community. And the reason that's really important is because we give the advisory board the power of the purse, meaning they have the power to approve the budget. And that makes them a lot more powerful. And was one of the mechanisms that we put in there to help the community maintain control over the non-police response program. We put in a short timeline so that there's only 6 months for the program to be put into, for the program plan to be put into place. And we strongly recommend that the government officials in the notes work with not only the advisory board, but talk to groups that are already doing this like cahoots so that they can figure out what call routing procedures to use, staffing requirements, protocol. And cahoots does provide technical assistance. I know they're overwhelmed, but it is it's very important to get the proper training for the mental health crisis workers. Okay. We also wanted some data and accountability to the public. But we didn't want too much data to be collected so that people who were experiencing crisis would not receive services because they didn't want their information to be collected. So I actually included, not here, but somewhere else in the law, that that services cannot be contingent on the person providing identifying information. That was very important to some of our impacted communities. And so we made sure to include that explicitly in the Act. The program plan has to be approved by the advisory board, and the data must be publicly posted and appropriately de-identified. So we can really see what is, whether or not it's working. Now, this is not included in the Act, but we do recommend that community groups and organizers define the outcomes in ways that are the outcomes that the community members want to see. So if they want to see decreased excessive use of force, that should be an outcome that is collected. It should be data that's collected. We didn't include outcomes in here because we wanted it to be designed by the communities. Let's see. So what differentiates our program, again, I've already said this, is that the non-police team is the solo first responder. So this is not a co-responder model. And the emphasis is placed on facilitating access to treatment if desired, rather than forced institutionalization. So we make it very clear that here's the section that says that they can't require identifying information to be provided, but we are careful in our language to make sure that treatment is not forced, to the extent possible, is not forced on the person that is amidst a crisis. We also wanted to make sure that people amidst crisis are receiving information about all different types of resources, not just preferred particular methods of treatment, like 12-step-based recovery programs. We also wanted it to include harm reduction services or other more stigmatized services. And let's see. Oh, and that includes medication for opioid use disorder, right? So again, we made sure that it's the least restrictive setting for follow-up care as possible. Now, funding is a changing landscape, and I'm not going to spend a lot of time here talking about the funding. Again, just remember the advisory board does have the power to approve how the budget is allocated, but we leave the issue of funding purposely vague because local governments get it from the state government. There's movement at the federal level to try to make some funds available. So we encourage you to take a look at a whole host of different funding structures. All right, so very quickly, implementation considerations. What other things should local governments be thinking about, even if they adopt our model law? Well, one is organizational structure. Should it be a local government agency that is the responder, or should it be a private non-for-profit entity? There are benefits for making part of the local government in that it is a lot harder to disassemble a government agency than it is to stop funding a private program. There also needs to be some thought given as to whether or not this should be the city or the county level. And we discuss in the paper in depth about why there might be some limitations legally as to what level it could be. We've also heard from community organizers that at times, even if they try to, or they have buy-in at the city level, the 911 dispatch is controlled by the county. And so they have difficulty getting buy-in if it is just a municipal ordinance. So there are limits on municipal power. So concluding thoughts. Police are trained to assess and respond to risk and to do so with hypervigilance. That's their job. By definition, that escalates behavioral health crises and it worsens health outcomes. There are too many people living with mental health issues and behavioral health substance use issues that have been traumatized, physically injured, and even killed by unnecessary police interactions. So it's really time that we begin to rethink police responses to behavioral health concerns.